And first of all, thank you, Dr. Letta and team, to having me here. And really, it's good to see a lot of people to whom we work, like Sir and Letta. So, just a minute. So, I think George has already explained very nicely how to do the trap. Yeah. So I feel really doing a trap really is a good art, how to do the trap, but more important is this, how you manage the trap. Most of the people can do the good surgery, but apart from doing the good surgery, how you salvage your trap for longer period of time is really a skill. So I personally say doing a trap is easy, but managing a trap is difficult. So here, what we do, why we do the Bleb revision. So what's the aim of the Bleb revision? To establish the restructure of the fistula between what we created during the trabeculectomy, between anterior chamber to the subconjunctival space. So when we should do the trabeculectomy, Bleb revision, first we have to understand the failing bleb. Why is bleb is going to fail, and what is the sign and symptom you have to look for. So what will happen? IP gradually increase postoperatively. So look for the changes in the bleb. So bleb become less diffuse, vascular, flat, and opalescent, and sometimes they be very elevated, smooth, dome shaped, and sometimes they lead like this, like the tenon cyst. So actually, the looking for these changes is very critical and early stage. So what we should do, first recognize these signs as early as possible, do all the conservative management, and when this conservative management fail, then we go for the filtering bleb. So let's understand why trap fails. So main reason is the failing either subconjunctival fibrosis, second is the subtenon encapsulation. Then understand where is the causes, where the site is going to be blocked. So first around the bleb capsule, then the skull flap will be adhered to the surrounding underlying tissue, and there is a sclerostomy. Your sclerostomy is closed. So indication of bleb needling, when we should do the bleb needling, so some prerequisites should be there. First, elevated IOP with deep chamber. There should be excessive scarring, encapsulation of the bleb, or episcleral scarring, unresponsive to the conservative management. Conservative management means give the lot of topical steroids, do the ocular massage, do the laser suture lysis. Really, nothing is works to salvage your bleb. Then only go for the bleb revision. So what should we do before bleb revision? Certain points we have to keep in mind. Always do the gonioscopy to rule out the blockage of the ostium, and look for the conjunctival mobility before doing the bleb needling. So you can take the simple cotton tip, and above the bleb, they should just touch it. So there should be some amount of the conjunctival mobility should be there. If it is not there, your chances of bleb needling survival is very, very less. Apart from that, really, when we done all the surgery, glaucoma patient really not very happy patient, like cataract surgery. Once you cataract surgery, patient very happy. You glaucoma surgery, again pressure high, really they got disappointed. And really they are not very happy patients. So again you ask for the one more surgery, really they need the very, very good counseling. They should have faith on you, then only you're ready for your bleb needling or second surgery. Otherwise, they give one more medication. Most of patients end up with give one more medication. So really talk to them, explain to them nicely, why do you want this surgery, and explain them, this is not the last resort. If fail, we need the further surgery also. So good counseling is very, very important before doing the bleb needling. Then what blade you should use? Probably it is all depend upon what works in your hand. Either 26 gauge needle, 27 gauge needle, 30 gauge needle, and some people use the MBR blade. I personally say what works in your hand, go for it. And coming to the use of antimetabolite, various studies have been suggested. Either you can use 5-FU or MMC during the bleb needling, but various studies have shown the MMC is more efficacious than the 5FU. There's a mixed literature about that. What the older studies are there, they say 5FU and MMC are equally efficacious. But in real clinical scenario, really MMC is much more effective than the 5FU. So how to do the bleb needling? Either you can do in the slit lamp bleb needling or in the option theater. I personally suggest first be master in doing in the option theater, especially countries like India where hygiene is little bit concerned. I prefer one should do in the strictly do into the option theater. Coming to the anesthesia, what anesthesia you use? Really, initially do with the peribulbar or subtenons, whatever the anesthesia was successful, but I'm not really very much advocate of the subtenant anesthesia. I strictly say go for the peribulbar anesthesia, because again, making one more opening into the conjunctiva, and really I'm not happy making my conjunctiva to be disturbed, especially my bleb is failed. And really, if you are master, then you can do in topical anesthesia by supplementing with the subconjunctival lignocaine. And all the aseptic precaution has to be taken. You can apply the brimodine drop before the bleb needling, so it will construct the so it will constrict the blood vessels. So coming to the, I'm showing the few cases how to do it. So this is I'm injecting the mitomycin C after taking the precaution, aseptic precaution, and keep your mitomycin C as posteriorly as you can do. Then I used to do always with the 26 gauge needles. So just bend it. It really works well what's in work hand, but around the 45 degree, 60 degree, and enter away 6 to 8 millimeter away from your bleb. And just be going, they have to take care, your bevel should be up. It should follow the globe. It should not be like this. You should follow the globe. And once we, so I will forward it here. So here I am trying to find out where is my flap here. Just find out, first remove this subconjunctival fibrosis and slit this needle under the flap. So just elevate the flap, and this is the moment when you go under the flap, the traction what you have, it become loosened. So you entered into the anterior chamber. And once you entered into the anterior chamber, you can feel it, this fluid gushing out from the eye, and you make the side port, and you make the anterior chamber. And sometime recently we start either doing the HPMC or the orogel, you can leave at the end of the surgery. This is another case in the phakic eye. There has to be taken really more precaution when we do the bleb needling into the phakic eyes. This is a similar way. I am injecting the mitomycin C, and after injecting my mitomycin C, just spread it as much as posteriorly. And I prefer, some people used to do with the rectus, but I strongly recommend better to do with the corneal traction suture, so you can avoid the conjunctival injury. And you can make the side port phakic eye, so you don't want to decompress the eye. Make a side port, put the anterior chamber maintainer, so it keeps eye firm throughout the procedure. And really, and this is the similar way, you away from the limbus, enter into the subconjunctival space, remove the subconjunctival fibrosis, and after removing the subconjunctival fibrosis, sometimes really the encapsulated bleb really hard to remove or cut it, really we have applied little force, but always keep in mind your needle bevel is visible, or it should be really away, not toward the globe, it should be always toward the conjunctival side. And once you remove the conjunctival fibrosis, then slit into the flap, under the flap. So under the flap, sometimes such cases we are not able to see, so we have to be very careful or understand where you find. So I am not able to find the flap from this side, we went to other side and find the flap. So once we find the flap, you can see the huge bleb has been formed. So this is the gentleman is Devendra. He is very innovative. He designed lot of instrument, and so this he developed the spatula. It's called the Grover spatula. So in this technique, good advantage there. Instead of touching the conjunctiva, you are doing the bleb needling through the inside from anterior chamber to the subconjunctival space. So similar way, putting the subconjunctival mitomycin C and spread it behindly. Only here we have to make the side port. So after making side port, form the AC with viscoelastic, and this is the Grover's spatula. And this Grover spatula, you have to come, you have to see where is your flap is here, come here under the flap and come into the subconjunctival space. So you can see here is my spatula is coming here. Only this problem, this patient don't try in topical because really it's a patient have the pain. You can see my spatula coming here in the subconjunctival space here nicely. Yeah. So once you do, you have to come, then form the AC. You can say nice Bleb has been formed. But I strictly recommend this technique has been to the selected cases only. So the Bleb needling, when we have to do the Bleb needling into the slit lamp, really some cases, really they are afraid of again going to the OR, there's a lot of psychological trauma, again the resurgery will be there is a little inconvenience and time consuming. In such case, once you are master in doing Bleb needling, you can try the Bleb needling especially into the OPD patients also. But patient has to be cooperative and really you have to be master in it, doing it, then you can perform. I strictly say this technique really works when there is subconjunctival fibrosis is there or there is some subscleral fibrosis is there. So just you go away from similar way, and first of all in this technique, first we lift the flap. So some of the aqueous egress from the anterior chamber, and that will give you a space to work to remove the subconjunctival fibrosis. So this technique is first go to the under the flap, then do it. Where the previous technique you have to do is first remove the subconjunctival fibrosis, then under the flap. So I think this is the some new another technique, the transconjunctival by Paul Pomberg. I'm not going to discuss here. So the risk of the failing the Bleb needling, IP more than 30 mg, tracheotomy done without mitomycin C, immediate IP is very high, and doing after long term. So post-operative care, always give the good amount of the steroid, and atropine has to be applied because again they tend to be have the shallow AC and malignant glaucoma. So atropine or homide, what is pseudophakic patient I use homide, and phakic patient I use the atropine. This has to given. Then coming to the complication, really some eye, even after doing the good trab or good trab region, keep in mind you can have the such complication, hypema, hypertony, series, malignant glaucoma, really they have to be keep in mind. So just to conclude, Bleb needling can rescue the failing Bleb, save the patient burden of the using multiple anti-glaucoma medications and the repeat surgery. Thank you for kind listening.
Thank you, sir, for the wonderful talk, wonderful videos. Now, few things like sir has shown it to be rather simple. It's not really a simple procedure, especially if you have subconjunctival hemorrhage happening on table. You will find it difficult to locate the edge of the flap, the suture that you had put earlier. And it's probably easier to do needling on the trap that you have already done. Rather than a trap which somebody else has done and which you don't know what shape of the flap was taken, where the needles were, where the sutures were put, etc. Now, regarding ab interno needling, like how do you exactly locate where the internal ostium is? Do you locate it pre-op or like what is your guide?
Okay, so I will go to your first thing you told now. Really, Bleb needling when he is really is not easy. I strongly recommend it has to be done by the glaucoma surgeon, not by the phaco surgeons. First of all, if you really thorough glaucoma surgeon, then do venture into such procedures. First thing, when you have the subconjunctival bleeding, only thing what you can do, take the spatula and spread it out. Usually, once you spread out, you can easily move the subconjunctival hemorrhage posteriorly, and you can easily locate the flap. Once you have done the surgery, your second point, seriously, I don't prefer to do somebody else done trap. I don't prefer to do Bleb needling. I go for the glaucoma medication, go for the other surgery. Because we don't know how big ostium he created, how small or big flap he has done, and what else he had done in the surgery. So I totally agree with you. So what your next question, sorry? Ab interno. So ab interno, really we have to see the preoperatively, and preoperatively how to identify where is the flap is there, your PI. PI is the marking. Probably we done the PI above the upper sclerostomy size. So on the site of the PI, you have to go and then you can find out the ostium.
I've just got a problem with that.
Yeah.
The primary pathology in a failed bleb is subconjunctival fibrosis. Whereas when you do this from ab interno, you really don't address that problem of the conjunctiva sticking on.
Yeah, so as I shown in my presentation, really is not only the subconjunctival fibrosis, sometimes we have the subscleral fibrosis also cause of the bleb failure. So especially the internal bleb region beautifully works when we have the subscleral fibrosis. And once you remove the subscleral fibrosis, you can go into this, especially is quite long. You can go as a atraumatic round tip, tapered round tip. You can go into the venture into the subconjunctival space also in both sides. So it gives you the quite good amount of working space in both way. You can remove the subconjunctival fibrosis also. But again, I will say it is really, you have to be master in doing it. It has some kind of learning curve when you do such kind of internal bleb needling.
Can I add one more thing?
Sure.
About both the points. One is this ostium doesn't have to be the center of the PI. So you have to do a gonioscopy and mark in reference to the PI where it is. Slightly to the right, slightly to the left, whatever. And now I do a peroperative tumor gonioscopy and make sure the tip of it goes in before I proceed. Then I take the gonioscope off and do the internal revision. The other question, I do the internal revision and raise a small bleb and sequentially do a needling for the conjunctival part. The problem is when do you need an internal revision? It's an old trab usually where the flap is already stuck down. You cannot make out where the bleb is. You cannot make out the edge of the trap flap. It's scarred that much. So you have to start off the bleb somehow and then do the needling.
Yeah, I think direct gonio lens is, if you're familiar with direct gonio lens, direct gonio lens really helps a lot.
I actually use the Zen's hand-me-down lenses.
Hi.
It's indirect for this purpose.
Yeah.
And I think internal needling probably is, it requires quite an amount of force to, find and open the
Under the block.
Yeah.
Under the, I told it's
Yeah.
painful,
Yeah.
so always do under the block only.
and you won't be able to cut a suture that is there. Probably the ab
No,
externo
we
will be
can't.
sutures you won't be able to.
Actually,
Okay.
basically we recommend always do the suture lysis, then only go for the bleb needling.
I've got a question from the audience. Dr. Philip Kurula wants to know whether subconjunctival mitomycin C will enter the anterior chamber if you are doing needling of the bleb.
Yeah, so what you have to do, you have to inject more posteriorly and you have to spread it as much as posterior you can do. So once you inject much more posteriorly, then what will happen once you're doing the bleb needling, aqueous is coming and really pushing that forward. So probably very, very less chances you can have the mitomycin come into the anterior chamber. And apart from that, you can, after doing the bleb needling, you can put some of the viscoelastics also to keep as a barrier if you feel. And some surgeon thought that viscoelastics work as a reservoir and helps in a non-healing. It won't heal so hard. Keep your tract open for longer period of time. Though we don't have much scientific effect on that, but some people leave the viscode after the bleb needling.
Can I add to that?
Good.
Pharmacokinetics of aqueous soluble mitomycin. In 1 minute, there are cadaveric studies which says 2/3 of it has disappeared from the site. So you wait 2 minutes, theoretically it should not be there. And about this heal-on, people are interlinking healer flow with our heal-on. That is cross-linked, this is not. So this should not be working.
Like if you are concerned, you can give the subconj injection 15-20 minutes before and then do the needling. That's what I do usually. If I am very, very, very afraid of the endothelial complications of mitomycin C, so I take a little bit extra, care. It is safe because these patients, if they, have 6/6 vision, you're doing these things. If they end up with endothelial decompensation, It's a very sad thing. So you can give it, I wait half an hour and then do the needling.
So actually, initially we started that, but slowly we moved to the, like sir told na, we moved to the 2 to 3 minutes because probably the volume is the concern for me. Volume is the major concern for me. So really we can't wait more than 3 to 4 minutes. So, yeah. Yes.
My biggest concern is the IOP the next day. There's no way you can predict that it's going to be high or low after needling the next day. You may be dealing with a shallow AC, you may be dealing with a totally failed needling.
So really, sir, recently what I have started, I am start leaving the orogel little bit into the anterior chamber. Really, it's avoid your immediate post-op complication like anything. Really, I will say my 95% patient, I didn't get the AC cello post-Bleb blending if you leave the little amount of the orogel into the anterior chamber. Rest, we don't know. Anything, surgery is surgery.
If you're doing needling, do it once, not more than that. Because personally, I feel a separate, properly done trabeculectomy is going to be more helpful in the long run rather than doing repeated needling. I see some eyes where they have tried 2 times, 3 times, multiple needlings. That's going to harm your conjunctiva and affect the success of subsequent surgery. So in my hands, I only do it once.
Okay.
Yeah, similar to ma'am. We follow the same. Once needling fail, our second step either do for the GDD.
Thank you. I think thank you very much for those
Thank you.
practical tips. Thank you for the audience interaction.